Greetings and welcome to Assessment and Management of the Cardiovascular Patient. This presentation is broken down into two different lectures. The first will be Assessment and General Management, and then the second will be Specific Cardiac Diseases. Today we'll be talking about Assessment and General Management of Cardiovascular Emergencies. Cardiovascular disease may affect the cardiac muscle or the myocardium itself, the electrical system of the heart, the sac or the pericardium that the heart rests in, or the blood vessels themselves. That general assessment approach is critical, a step-by-step process, so you do not miss anything when you assess your patients, especially your cardiac patients having maybe a life-altering event. Remember those GLTs. It's easy as A, B, C. Then you look at these, expose these, and set your priority. That doesn't change. And look for those serious signs and symptoms. Do they have altered mental status? JVD, which could be a sign of acute heart failure. Are they having chest pain, hypotensions? And look from head to toe for signs and symptoms of shock. Various diseases of the cardiovascular system are MIs, heart failure or cardiogenic shock. In the conduction electrical system, are they going too fast or too slow? In your pericardium, do they have the itis, the inflammation, the pericarditis, or tamponade, and get that squeeze? And then in the vasculature, you can have arterial or venous occlusion or pulmonary embolisms. And we'll talk about those when we talk about specific diseases in the next presentation. Treatments in the field are limited. We can give nitrates, aspirin, control pain for that symptomatic cardiac issue. You can treat pulmonary edema and take care of the patient emotionally. They could be thinking they're having the big one and they're gonna die. So comfort that patient and their family during this event. Let's talk about some assessment techniques of our patients. Top bullet, cardiac disease may present as shortness of breath, dyspnea, or difficulty breathing. So don't just be tunnel visioned on a lung problem. Do not be tunnel visioned on a lung problem. Remember that GLT. It's easy as A, B, C. Then you look at these, expose these to set your priority to end that primary survey or initial assessment. Remember, with your general impression, you have your adult assessment triangle, your FEDSO, WARF, and patriotic patients. Are they red, white, or blue? If you haven't seen my adult assessment triangle, find it on YouTube. Remember that breathing, that difficulty breathing, can be due to the heart not pumping fluid out to the body. And if it doesn't pump fluid out to the body effectively, it starts to get backed up in the lungs. Then those moist crackles can be an indication of heart problems. So when you're doing your assessment, pay particular attention to those breath sounds. And also note that circulation. Are our patients patriotic? Are they red, white, or blue? Get that skin temperature and that texture. So that Tuger, pinch their skin, see if it snaps back wash after wash, or does it stay tented because they're dehydrated? Look for that JVD and that pedal edema and the rate and quality of pulses and that blood pressure. critical things to check out in the first few minutes of your assessment. When you start focusing on your history, remember all of those acronyms. Remember the O, P, Q, R, S, T, and T. So we've added a T to the end of it. So onset is when it started and what you were doing. Was I shoveling snow and I started getting this chest pain, mowing the grass, physically exerting myself? So provocation, what makes it better or worse? The quality. The quality. Is it sharp? Is it stabbing? Is it pain? Is it pressure? You may have to ask some leading questions here. So does it radiate? Ask them if it moves anywhere. And severity. On a scale of 1 to 10, 10 being the worst pain you ever felt in your life. And then ask them what that worst pain was that they ever felt. Because it could be a big difference between a hangnail being their worst pain and getting their leg blown off in battle. So ask them what that worst pain is. Then the T, how long has it lasted? Does it come and go, or is it intermediate, or is it constant? And have you done anything to treat yourself? Are important questions for that chest pain history. Then labored breathing, like we said, can be from congestive heart failure or an MI. So note that onset, the duration, anything make it better or worse. Positional breathing issues. If they are coughing, ask if it's a dry or if it's a productive. And if it's a productive cough, then you need to ask what colors it is of the sputum they're coughing up. All important things. Some more signs and symptoms that your patient can be showing and telling you. Note that level of consciousness. Make sure they are alert to person, place, time, and event. Look at that skin for diaphoresis, because if they're diaphoretic, they're fixing to die. And that's the body's sign, the cry for help. Are they restless or anxiety-ridden? If they're anxious, think hypoxic brain and check that O2 sat. So we want an O2 sat between 94 and 99%. Do they have that feeling of impending doom? Go ahead and click on the link. If the link's not working, copy and paste the URL into another web browser and then pause the presentation and watch A Feeling of Impending Doom from Sanford & Son back in the day. Do they have any of these other type of issues? Nausea, vomiting. I just don't feel like moving. It's hard to get up. That fatigue. Do they think they're going to pass out? Things like that. Look for all those other signs and symptoms when you're assessing these cardiac patients. All right, once we're done with the OPQRST-T, we're going to walk through sample. SAMPLE, and now we're going to put an on it. We'll talk about the risk factors later on the next slide. Allergies. What allergies do they have? Are they true allergies or just, oh, it upset my stomach when I took them? So get some pinpoint, definitive answers with these questions. Are they on any kind of medications? So do they have a list or just take them all with you to the hospital? Are they compliant with that medication? Do they take it, or have they been out for a few days and that's what's caused this issue? Are they taking any supplements or over-the-counter medications or any recreational medications? So get all of those answers too. Very important for the medication question. Next is past pertinent medical history. You can pick your friends, but you can't pick your genes. So if you have a family history of cardiac issues, you will probably end up getting some yourself. If granddad, dad, Uncle Bob, those guys died of a heart attack at 50 some years old. Well, your time's ticking too. So check out that. Last oral intake. Am I having palpitations because I just chugged 5 monsters? Well, maybe. So events preceding. Were they shoveling snow, mowing grass, things like that? And then risk factors. We're a sample now. Risk factors. Do they smoke? Are they overweight? Things like that. So check that out in your history. Remember, with your assessments, we IAPP, we inspect, auscultate, palpate, and percuss. So on your inspection, look at the neck. Once you get done with your ABCs, look at that neck for the presence of JVD. Expose the chest. Look for that cardiac scar and tattoo on their center of their chest. So look at do a pulse motor and sensory, and look for their cankles. If they have fluid backing up in their legs, it's because the heart isn't pumping it out correctly. So notice those subtle signs. Auscultate. Adventitious breath sounds. Listen for that stridor and rhonchi. Remember, the rhonchi is in the bronchi and those big wind pipes. Your wheezing is going to be in those lower areas. And then, of course, we're going to the backles to hear the crackles or the rails. You're going to hear those in the posterior aspect. The crackles are in the backles. So listen to them, because it's going to collect in the base, in the bases, on the posterior aspect of your lungs. Once you do your lung sounds, then you do your heart tones. You're going to start off with that PMI, the fifth intercostal space, mid-clavicular line on the left side. That's where your apex of your heart is located. And that's when you're going to get that nice big sound. Point of maximum impulse. Then you're sliding over to S1, the AV valves, and then up to S2. So in this picture, the pink is your PMI, the green is S1, and S2 is the yellow in this picture. Also, with our cardiac patients, let's auscultate for carotid artery bruits. And that's just turbulent blood flow through a partially occluded vessel. You're going to look in this area, right at the edge of the jaw. Let's get a bigger swipe here, big swipe here. You're going to listen right there. And you're going to hear a whoosh, whoosh with every beat of the heart. It may sound like cheeseburgers, cheeseburgers, cheeseburgers from all that cholesterol developing plaque. So listen for bruits there, because we may have to do a carotid massage if they are fast, tacky, and we'll talk more about that in a second. Palpitation. Of course, we're going to palpate for pulses, radial pulses, carotid pulses, pedal pulses, or posterior tibial pulses. We can also palpate the rib cages to rule out any musculoskeletal causes of chest pain. So, and you can palpate the epigastric area for any pulsating masses also. And look for any subcutaneous emphysema. Subcutaneous emphysema in that upper area. around that sternal notch. It can feel like little packing can feel like packing bubbles, and it may even sound like Rice Krispies. Snap, crackle, pop. That's a general assessment of our cardiovascular patients. Let's talk about some general treatments for them now. If their heart is not beating, then we need to do CPR. And doing it correctly, hard and fast, at least 100 to 120 beats a minute nowadays. So take a break from the presentation, click on the link, Staying Alive CPR, or copy and paste the URL into another web browser and watch this little presentation. Hey, once you're back from that little intermission, you talk about various advanced life support procedures, EKG monitoring, vagal maneuvers, precordial thumps, and all the other ones we're going to touch on in the next few slides. Basic paramedic care is an IV and a cardiac monitor. Everybody should get a 4-lead, at least a 4-lead. And remember that lead 2 goes from right arm to left leg. But you don't have a clue in lead 2 for real cardiac issues. So if it's a cardiac patient, put them on a 12-lead. All right, ECG, remember, you're just looking at the limb leads. RA, right arm, LA, left arm, and things like that. It is pretty simple. Salt, pepper, ketchup, snow over grass, smoke over fire, however you want to remember it. Just look at the leads and put them where they tell you. Most common cause of faulty EKGs is skin contact. If they're big and hairy, you might have to shave it to stick that electrode on there. So service your equipment, make sure the batteries are good, cables are good, all that type of stuff, so you don't get any faulty skin contact. Let's talk about vagal maneuvers. Indications: they are fast, and they are stable, and they are narrow. They are fast, stable, and narrow, SVT. SVT, basically. So we're going to try various vagal maneuvers. You can Valsalva, pinch your nose and blow out with a closed mouth to send air up your eustachian tubes to equalize the pressure in your inner ear, may work. Taking a nice deep breath and blowing through a thin straw or a syringe may increase that pressure and cause it to work. Bearing down like you're having a bowel movement may also work. So to stimulate the vagus nerve, which is linked right to the parasympathetic nervous system, to slow the body down. If those don't work, you're going to do a carotid massage. Like I said, you're going to auscultate for bruits, and then you are going to push right at the corner of that jaw, because your 10th cranial nerve, the vagus nerve, runs in a sheath with those carotid arteries. And we need to push hard enough to dent a tennis ball for about 10 to 15 seconds. Push at the corner of that jaw hard enough to dent a tennis ball, 10 to 15 seconds to stimulate that vagus nerve and hopefully lower this heart rate that is fast and stable and narrow. Some complications of carotid massage: the patient may become bradycardic. They could experience some nausea, maybe even some vomiting. Remember not to do this procedure on patients that have carotid bruits, those cheeseburgers, when you auscultate. And also, if this is a previous stroke patient, don't do this procedure. Find another vagal maneuver to try. Yes, it is true. Sort of like on TV, that precordial thump is still in the textbooks, so we still teach it. However, the big red letters on the screen, it's used only for a witnessed arrest. Only for a witnessed arrest. I'm going to put that elbow in their belly button and hit them mid-sternum from 10 to 12 inches away, and that'll provide about 10 joules of electrical charge on your heart. If they've been down longer than that, don't waste your time with a precordial thump. Get the pads on there and defibrillate. VFib and pulseless VTAC. And hey, don't beat kids. Therapeutic electrocution, defibrillation, chest wall resistance, big muscular guys, big hairy chests. Like I said, we need to get those pads on them and make that heart sandwich, either anterior, posterior position of those pads, or right upper chest, left lower chest to sandwich the heart. Successful defibrillation depends on all of those factors. The steps are, hey, place the defib pads, set your joules or your energy setting. Remember to continue compressions. We're defibrillating dead people, so you're doing CPR right now. So continue compressions while the monitor is charging. Once it's charged, you're going to clear your patient. You're going to push the shock button, and then if they're in VFib or pulseless VTAC, you're going to continue CPR. So minimize interruptions in CPR to less than 10 seconds. So it's timing with your defibrillation every 2 minutes. The second thing we'll talk about with therapeutic electrocution is synchronized cardioversion. If your patient has a fast rhythm and they are unstable, you go to synchronized cardioversion. Fast. It can be wide or it can be narrow. But if it's fast and they are unstable, meaning they have one serious sign and symptom. The American Heart Association says there's 5. They have altered mental status. They have signs of acute heart failure, which is JVD. They have chest pain. They are hypotensive, or they have signs and symptoms of shock. They're pale, cool, diaphoretic. If they have those, they are unstable, and they only need one because they're all serious. Only one because they're all serious. And fast, unstable, synchronized cardioversion. Perfusing VTAC, PSVT, AFib, A-flutter. The steps for synchronized cardioversion. We're sending electricity through a live patient, so sedate if possible. But if they have a serious sign and symptom, because we're doing this, so don't delay therapy to give them pain control. We're going to turn our monitor on to sync. Hit that sync button. You'll see the inverted triangles or the tick marks, and the little sync will blink. Then set your rate. Look at the picture. If they are narrow and regular, SVT or PSVT, you can start at 50 to 100. If they narrow and irregular, AFib, 120 to 200 most of the time, we go 150. So if they are wide and regular, VTAC, we're starting at 100. If they are wide and irregular, torsades, you're going to defibrillate those live people. So we're going to sync, turn the sync on, set. We're going to charge our monitor. We're going to clear our patient, and we're going to push and hold the shock button. We push and hold the shock button so the computer synchronizes that electrical discharge on that R wave in hopes to slow this fast unstable rhythm. All right, synchronized cardioversion was for fast, unstable patients. Transcutaneous cardiac pacing is for slow, unstable patients. Symptomatic or unstable bradycardia. Remember, if they're symptomatic or they're unstable, they have one of the serious signs and symptoms. Altered mental status, acute heart failure, JVD, chest pain, hypotension, or signs and symptoms of shock. So, most of the time with our symptomatic bradycardias, we're going to start with atropine. Always pace dangerous events. Atropine pacing, dopamine epi. So, unless they have a high degree AV block, which is a type 2 second degree or third degree, we can go straight to pacing. So, the 4 steps for pacing are pacer, rate, current, capture, pacer, rate, current, capture, pacer, rate, current, capture. We're going to make a heart sandwich. We're going to turn on our pacer. Turn on the pacer, set the rate between 60 and 70. And some books say at least 20 beats faster than their initial rate, but in between 60 and 70. So then you're going to increase your current until you have electrical capture. You're going to see some pacer spikes between your QRS complex, and the rate on your monitor will match the rate you set on your pacer. Once that occurs and you've achieved electrical capture, then you're going to increase your current by 2 milliamps, 2 to 5, to maintain it occurring. And then, after you have electrical capture, you're going to take a radio pulse to see if you have mechanical capture. If you don't get electrical and mechanical capture, then your pacer is not working and you progress down the algorithm. Always pace dangerous events, atropine pacing, dopamine epi. If you haven't watched my pacer video, you can copy and paste this YouTube link into another web browser and take a short look. All right, when you've tried all these other procedures and things aren't working, we may have to go to some medications. Medications we'll talk about are some antidysrhythmics, some sympathomimetics, some drugs for MIs, and other medications. Drugs in the antidysrhythmic realm are adenosine. Remember, we're using adenosine for fast, stable, and narrow tachycardias, SVT, because it's going to slow down the signals going through the AV node. Remember, your adenosine sentence is 6 milligrams rapid IV push followed by 20 cc flush. In 1 or 2 minutes, we're going to give 12 milligrams rapid IV push followed by 20 cc flush if the first one didn't work. So atropine is for bradycardia. So atropine doesn't speed up the heart, it just blocks the parasympathetic signals that slows the heart down. Amiodarone is for our tachyarrhythmias, VFib or pulseless VTach, and VTach with a pulse. So it slows down the action of the sodium-potassium pump at the cellular level. So it works at that cellular level. That's why it is so powerful. Diltalzam or cardiazam are calcium channel blockers. Remember, calcium, that electrolyte, helps sodium with depolarization of the cells and also with that muscle contraction. So it slows things down by blocking those calcium channels and blocking calcium from getting in and helping out with depolarization. Lidocaine It's a cane drug, so it's going to numb some things. So basically it numbs your heart to slow it down. Then we have procainamide, reduces cardiac conduction in the atrium, the ventricles, in the Purkinje system. So it's that negative dromotropic electric properties. And then sotalol, that olol drug, is a beta blocker. It's a beta blocker. Remember your mnemonic: cardio, contractility, automaticity rate, dilation of your beta 2s and your bronchioles. And if we're working harder, we have irritable and more oxygen demand. But beta blocker blocks the contractility, the automaticity, electrical conduction, and the rate, so it slows things down and drops your blood pressure. Sotalol, beta blocker. Are sympathomimetic drugs. Mimic the sympathetic nervous system, our body's gas pedal. The primary one in emergency medicine is epinephrine. Then we have epi's big brother, norepinephrine. It's more potent alpha. And if you remember the alpha squeeze, you pull these tails of the alpha fish and it vasoconstricts our A's. So remember alpha, vasoconstriction. So isoproterenol is pure betas. Beta 1, one heart, beta 2, two lungs. It works directly on those betas. Then we have dopamine, which is dose dependent. You can get beta properties at a dose of 5 to 10 micrograms per kilogram per minute. Or we can get more alpha properties with doses of 10 to 20 micrograms per kilogram per minute. Then there's dobutamine, which takes care of that inotropic, I know squeeze my heart, yeah, I know squeeze my heart, the contractility of the heart. And then vasopressin. Vasopressin is a vasoconstrictor, aka antidiuretic hormone. Mo drugs. Take a look at all these crazy drugs. One good thing about cardiology, it comes in the middle of the paramedic program, and you guys have actually passed about 64 drug quizzes already, so you have at least an introduction knowledge, and some of these are working knowledges of these medications. So take a look at them and then think back to those drug quizzes and what we emphasize about each medication. Drugs for MIs. Remember Mona. Morphine, oxygen, nitro, and aspirin. Mona. Morphine, oxygen, nitro, and aspirin. We don't give those in that order. We normally start out with some oxygen if they are hypoxic, less than 94%. Then we give that 324 milligrams of aspirin and a nitro if their blood pressure supports it. So, and then we're using morphine or fentanyl nowadays is the trend for cardiac pain control. All right, fibrinolytics, those clot busting drugs can help. So the studies are still out for in the field or not in the field. So it just depends on the flavor of the day. But that's the great thing about emergency medicine. It changes all the time with science-based medicine. So we'll talk more about the fibrinolytics with specific diseases lecture next. Some other pre-hospital drugs. Furosemide, that loop diuretic we used to use all the time for CHF. Now it's not used that much. It comes and goes. So it just depends on your medical direction if they prefer to use it or not. So promethazine was used for nausea and vomiting, and now it's basically been replaced with Zofran. And then some cardiac patients are actually on a nitro drip, sodium nitroprusside. You may see that during interfacility transports. Times are changing. The drugs below were infrequently used in the pre-hospital settings because we didn't even have them. But nowadays we're starting to get them on our ambulances. We have labetalol, a beta blocker now, and we have Cardiazem, a calcium channel blocker now that we can use in our pre-hospital settings. So, and prolonged arrest patients to combat that metabolic acidosis, it's standard nowadays to give sodium bicarb. Check with your local protocols and your medical directors to see what you have at your disposal to use when needed. Remember, you are helping these people at the most critical time in their life. Cardiac patients, they could have that impending feeling of doom, like they're gonna die. So you may have to treat their family members as much or more than the patient themselves. Emotional support, a good, clear, concise handoff report at the ER to relay everything you have found and done with your care in the mobile machine called our ambulance. All right, once again, we are back to everybody's favorite slide in summary. So we've talked about general assessment principles of our cardiac patient and general treatments of them. Go ahead and click on the link, and if the link doesn't work, copy and paste the URL into another browser and listen to it. This will trend into the next cardiac lecture. Enjoy. Until next time, have a good day.